Nobody can underestimate importance of cleaning of uterine cavity with doing a DNC, which helps in conceiving. Nowadays, hysteroscopy is combined along with curettage, and hence this procedure is called as hysteroscopic curettage. Hi, I'm Dr. Radhika Bandari from Dia Fertility Center, Esra Nagar, Hyderabad. This is a case of thick polypoidal endometrium, which is commonly seen in PCOS patients who have irregular shedding during menstrual cycles. Her scan has showed thick endometrium along the anterior wall, and there was no triple line endometrium. I tried treating her with norethistron, but polypoidal endometrium persisted, so I decided to go ahead with hysteroscopy. Not just DNC, because DNC is a blind procedure. Hysteroscopy we can see and treat. Only caution is hysteroscopy requires what normal saline as a distension media. Fluid overload is a problem, so has to be completed quickly enough. Now let us see how the hysteroscopy is being done. First of all, I'm looking at the internal os of the cervix, which is the gateway for the uterine cavity. We are trying to see the entire uterine cavity. First of all, uterus has four walls: anterior, posterior, lateral walls, and the roof. Each wall has to be seen. A close look at the anterior wall shows that there is fluffy endometrium on it, which is our target area. We can see few strands of endometrium hanging just beyond the internal os level. First step that we have to undertake is to cut those tags which are hanging into the uterine cavity from the level of the and from the anterior wall just beyond the internal os level. To do so, the scope has to be withdrawn. Surgeon has to move backwards. He has to lower his hands completely. Only then the inner end of the scope can face upwards. The scissor, which was still then inside the hysteroscope unit, now will move forwards and reach the base of these stacks. Open the blades of the scissor wide and cut these stacks from the base itself. So now, as we have cut the tags, next we have to take care to remove the endometrium which is stuck to the anterior wall. Slowly now we have to lift the hysteroscope unit in such a way that the scissor that we are going to advance remains parallel to the wall of the uterine cavity, along which it has to move forwards and backwards. The depth to which the scissor has to be insinuated within the endometrium depends upon the depth of endometrium that we want to remove from that area. Appropriate assessment of this depth will ensure that we can take maximum extent of the polypoidal endometrium in one go. This will reduce the time required to complete this procedure. Just as we have completed one line, then again we have to come back, again move forward in the line adjacent to the area that which we have already cut. From near the internal os, the cutting goes forward till about the roof. So this kind of procedure or cutting this endometrium goes on till about the entire anterior wall of the uterus is bared of the polypoidal endometrium. Now that the entire anterior wall of the uterine cavity is bared of the polypoidal endometrium, now we are moving towards the opposite lateral wall. It's very difficult for a right-handed surgeon to approach the left lateral wall of the patient's uterine cavity and to cut along it. But a trial is given. One goes about cutting the lateral wall endometrium as well as much as possible. Few endometrial tags that are dangling into the uterine cavity are not having any blood supply and also are not firmly attached to the uterus, and hence they will get shed off on their own or might come out during next menstrual cycle. Now it's time to give a nick to the roof of the uterus. The portion of the fundus which is dipping into the cavity is cut in the middle, and the nick is then extended to both the sides. This kind of nicking of the uterus in the roof increases the chances of her conceiving. I hope this video has been informative. Thank you for watching. Please like and subscribe.